Good morning, everyone. Welcome to our Phoenix Children's Grand Rounds, first of the month for November. It's my pleasure this morning to introduce one of our pediatric pulmonologists here at Phoenix Children's, Dr. Sophia Williams. Dr. Williams completed her pulmonary fellowship at Miller Children's Hospital in California. She offers children with a full range of respiratory conditions and most advanced approaches to diagnosis and treatment. She specializes in cystic fibrosis, mobile asthma care, pulmonary hypertension, and bronchopulmonary dysplasia. Dr. Williams is active in local and state professional organizations and has been recognized as one of Phoenix Magazine's top docs for the last 4 years. She's a Cystic Fibrosis Foundation advisory member, a committee member for the Program Evaluation and Pediatric Residency Committee, as well as a continuing medical education committee here at Phoenix Children's. And she also serves as a pulmonary rotation and pulmonary fellowship director here at Phoenix Children's. Outside of work, Dr. Williams enjoys cooking with her son, dancing, and traveling. So Dr. Williams, a very warm welcome to your own institution. We look forward to an excellent talk on emerging concepts in chronic management of asthma. Take it away.
All right, good morning. Thank you. And thank you for having me. Can you hear me okay?
Yes, I can.
Perfect. So as noted this morning, I'm going to talk a bit about emerging concepts in chronic management of asthma. I can talk about asthma for days for sure, but I'm going to try to narrow it down to some of the changes as we relatively recently had new guidelines for asthma. The older guidelines were out in 2007, and 13 years later, we were able to come up with new guidelines. So I'll highlight some of that and some of the newer therapies for our asthmatic patients. So first, I'd share that I have no financial disclosures relevant to this presentation. And then I'm going to share this slide. I'm going to attempt to do some Slido questions throughout the presentation. So if you're able to either join slido.com or use the QR code, that way when the questions come up, you'll be able to participate. All right. So the objectives for today, to try to differentiate asthma from other causes of cough and wheeze, understand the current guidelines for the diagnosis and management, integrate new treatment options, including what's called biologic agents in asthma management, and then recognize that poor adherence rates as a limitation in asthma management. So I'm going to start with the case. It's a 2-year-old male with 3-month history of recurrent cough and wheeze. He had a similar episode about a year ago. Cough is worse at night or in the early mornings, and also with clear rhinorrhea in the mornings. Several cough preparations have been tried without change. He's been seen in the ED twice to date, treated with albuterol and prednisolone with interval improvement. Medical history is notable for 30 weeks gestational age, history of eczema, although no recent flares, family history with mom having asthma, and then environmental factors where dad smokes. So I'm underlining a couple of keywords or key phrases, and unfortunately it's never this easy, but sometimes we do get everyone with all of these factors. So let's try the first poll. What do you think is the diagnosis of this case, of the patient? I'll give another 30 seconds. All right, so no one picked the allergy part, which is good. We'll see why in a second. There are a few that chose bronchiolitis, and I'll highlight why this is a little bit of a trick question. But the majority of individuals went with asthma, which is where I was trying to go. Now, before we go on to what is asthma and management, what if it isn't asthma? What are the things that we kind of look for? Vocal cord dysfunction, or otherwise termed exercise-induced laryngeal obstruction, is something that can be causing some of these cough or shortness of breath symptoms. A lot of time that's elicited by history, as well as when we do pulmonary function testing in clinic, there's certain patterns that we can elicit corresponds to VCD. This entity called protracted bacterial bronchitis, it's still debated in the pulmonary world, but the idea of sort of a wet sounding cough for greater than 4 weeks, that's usually responsive to prolonged antibiotics. That's another etiology that we explore and sometimes need to treat. Cystic fibrosis, especially if there are other organ systems involved, GI being the most predominant in many of our kids. We'll explore that. PCD, or primary ciliary dyskinesia, or newer terminologies, immotile ciliary syndrome. And that's another one that can present with wet sounding cough. Allergic bronchopulmonary aspergillosis. It's a little bit of an asterisk because it's not necessarily a standalone diagnosis. Many asthmatics, severe asthmatics, can have ABPA as part of their course, but ABPA can be with other entities such as cystic fibrosis. Reflux, especially if there's nocturnal cough being the predominant symptom, there's still evidence that reflux can play a role causing laryngeal spasms and cough. Aspiration, particularly if you're getting a history of feeding difficulty, wet sounding cough, we can look for that, and certainly airway abnormalities, including structural abnormalities such as bronchomalacia or even foreign body. So these are a couple of things that we do look into, especially if the history suggests that can present with similar symptoms of asthma, but really is not asthma. But this kiddo has history of cough, again, worse at night, has a recurrent symptom. So the recurrent part is what's highlighted. That's usually what we will look at to differentiate from just bronchiolitis alone. Yes, we can certainly have 1 or 2 episodes separated, maybe yearly. But if you're having a history where there are multiple episodes even within the year, the magic number by studies, which you'll see in a second, is 4. Usually you're pointing more to kind of an asthma picture. The idea of wheeze in addition to cough. So wheeze is an entity of lower airway involvement. So again, many of you did not choose allergies, but we get that a lot, especially when kids are coughing by itself. When we hear the story of wheeze in addition to cough, usually allergies is not the sole cause. It certainly can be the trigger and a component, but it's usually not the sole cause. This could also have eczema. There's a family history, there's environmental exposures, and it's relieved with beta agonist. So like I said, this vignette I get to create, and many of the kids that come to us don't have everything in line, but this kid sort of highlights the main things that we're looking for. And then you can say, well, he's only 2, so how do we actually approach the diagnosis of asthma in kids that are younger than 4 years of age? And there's a study that actually were done by colleagues here in Tucson that looked at hundreds of kids and really came up with a way to predict if asthma is going to develop. And they came up with this asthma predictive index, whereby there are major and minor criteria. Again, if they have wheezing more than 3 times in a year, plus at least 1 of the 2 major criteria or 2 of the 3 minor criteria, then their likelihood of having asthma is higher. There are actually tools online. This one is from Cincinnati Children's Hospital that you can plug in sort of the answer to those respective questions, and it will tell you high risk, low risk, moderate risk by the age of 7 in terms of developing asthma. So what is asthma? So it's an episodic and reversible airway constriction and inflammation in response to infection, environmental allergens, as well as irritants. And again, keywords are highlighted. So this idea of inflammation, it stimulates airway hyperresponsiveness and airway obstruction. When I talk to a lot of the families, I tell them actually think of balloons. And if you can imagine blowing up a balloon, letting it out, everything's great. You blow up a balloon and you kind of put your hand on the neck of the balloon. That's sort of our airways. And now you have forced air going through a smaller airway. That's where that wheezing sound is coming from. In the body, again, we have muscles that are going to contract to open up those airways, and that spasm is really where your cough symptoms are coming from. So you have this idea of hyper-responsiveness, you have this idea of airway obstruction, creating those clinical symptoms. Now, over the years, the studies have shown there are genetics that play a role, environment plays a role, and then this idea of innate immunology, or excuse me, innate immunity with Th1 and Th2. And by no means do I know immunology that well, but as it relates to asthma, it's really important, and it's contribute to a lot of the newer therapies that we utilize right now. When we first started classifying it, we looked at the phenotype, and you heard statements such as extrinsic or allergic asthma versus intrinsic asthma. Extrinsic asthma was defined as more of your allergies triggered by allergen exposure, atopy confirmed on skin testing, elevated IgE, versus your intrinsic was sort of the opposite. That then progressed on to more finite definitions of eosinophilic versus neutrophilic. And again, staying in the same columns, extrinsic, external, allergic, eosinophilic versus intrinsic or now neutrophilic. And again, your eosinophilic asthma, you're notable for high eosinophils in your blood or your sputum, typically have mild to moderate severity in terms of clinical presentation, and typically have Th2 driven inflammation. And we'll continue to go through that in a second, versus your neutrophilic asthma, which is really important. They tend to be less responsive to your corticosteroids. Neutrophils are really hard to address. They actually tend to be more of your severe cases of asthmatics. And some of the more recent studies are looking at the Th17 pathway for these individuals. Continuing in that idea, we went to classifying asthma by endotype. And you have, again, that type 2 airway inflammation, Th2 driven. Eosinophils, again, are centrally involved. They are the mediators of your airway response to outside substances, and they modulate the adaptive immune cascade within the lungs. And you have this idea of Th2 high, Th2 low. Just kind of note, and we'll show a picture in a little bit of the fact that Th2 secrete certain interleukins, particularly IL-4, 5, and 13. And again, we'll highlight why that's important in a second. So looking at this idea of Th2 high, continuing down sort of that column of extrinsic, allergic, eosinophilic, and now Th2 high asthma. These are the kiddos that will present early in terms of symptom, classified with eosinophilia, responsive to glucocorticosteroids, evidence of atopic disease, and they have some response to inhibitors of type 2 inflammation. Versus your Th2 low, which is your opposite. You've got more late onset. You tend to have absence of eosinophilia, and actually it's the neutrophils that tend to fill that gap. They actually are not as responsive to glucocorticoids, and they tend to have a little bit more ENT findings as well in terms of chronic rhinosinusitis and nasal polyps. So starting out, severity of disease. So this is an age-old chart. It looks pretty busy, but trying to break it up into sections. The top part will give you your classifications. You either have intermittent or persistent asthma, and within your persistent category, you have mild, moderate, or severe. And then it's broken down by ages, part because a certain age group will show certain symptoms. Certain age groups cannot do lung function testing, and there are different treatment options per age group. Then on the side, you have impairment versus risk. Impairment tends to be the questions that we are asking in terms of their symptom presentation. And risks tend to be how bad is their asthma that's warranting medical attention. So I always think of kind of rules of two. Your intermittent patients usually are less than 2 days a week. in terms of your cough, mainly, or wheezing, less than 2 times a month for nighttime awakenings, etc. Your mild tend to be more than 2 days a week, but not necessarily daily. Then your moderate tends to be daily, and your severe tends to be several times throughout the day. And then if they're able to and old enough to do PFTs, your lung function objective findings are there as well. So these are what we use to try to categorize, again, the severity in the diagnosis of an asthmatic. Are they intermittent? Are they mild, persistent, moderate, persistent, or severe? The important thing, again, is risk. So if you have patients that are presenting or clinically telling you symptoms that kind of fall in sort of an intermittent or maybe even a mild persistent range, but when you ask them about ED, emergency room visits, or even hospitalizations or use of oral steroids, and they're telling you they're using it several times a year, that goes into that risk category, and that actually trumps impairment. So if their symptoms are otherwise telling you that they may be mild persistent, but they're getting 2, 3, maybe even 4 oral steroid courses over the year, or seen in the emergency room over the year, that actually bumps them up into sort of a moderate persistent asthma category. And likewise for the other categories, it kind of steps them up when their risk factors are higher. So quick notes about prematurity, even though that was not one of the things studied in that Tucson study, other studies have actually looked into it and have realized and shown children born very preterm, usually less than 32 weeks gestational age, tend to have higher prevalence of asthma. One such study kind of showed 11 or close to 12% versus 8% in term births. So that's sort of a risk factor that you sort of keep in the back of your head. In terms of testing, a quick note about that, spirometry is sort of our main one. We usually will perform it by age 5 years and older. Sometimes the kids are savvy and we'll try to get it in 4-year-olds. We may squeeze out a 3.5-year-old, but those tend to be not as reliable. So really you're targeting your 5-year-olds and older. What we're looking for is evidence of airflow obstruction. We look at FEV1 as an isolated parameter, but we also look at the ratio of FEV1 to FVC, forced expiratory volume in 1 second versus forced vital capacity. And if that's decreased, that is one of the factors evident for or confirming an asthma diagnosis. The other big one is something called reversibility. So after we give them a bronchodilator, usually albuterol is the drug of choice. If we see at least a 12% increase in the parameters post bronchodilator, that is evidence of reversibility. And again, that's another component that would confirm or raise the suspicion for asthma in the particular patient. The other testing that's available is FeNO, or fractional exhaled nitric oxide. So for many of us, it tends to be an adjunct test. It had a lot greater weight when it first came out, but it really never showed superiority in testing compared to sort of the pulmonary function test. So for most, that it's now become an adjunct component of measuring airway inflammation, particularly if a kid or a young adult has normal flows, but they still have symptoms that are concerning for asthma. You may be able to use this and elicit airway inflammation and still kind of confirm your diagnosis of asthma. The numbers actually will differ a little bit by the companies running the test, but generally greater than 35 parts per billion is abnormal in ages 5 to 12 years, and then 50 is kind of the cutoff for older than 12 years. Again, look at the vendors. If you are using FeNO, they do actually have different cutoff numbers. And certainly an abnormal parameter indicates elevated T2 inflammation and likely asthma. So why is asthma so important? Outside of the fact of the symptoms that kids and young adults experience and how miserable it can actually make them, asthma as a diagnosis remains among the leading cause of morbidity and mortality. It still has a high prevalence and high economic as well as productivity burden, particularly in children. So this is from the CDC, and this is actually showing the number of, or the percent of days missed in children with asthma, and as well as the total number of days amongst all the asthmatics that they looked at, and all the days that they reported, the total number of days that were missed. So on this side is going through the percentage, and you can see even in a 10-year span, 2003 to 2013, we still have well over 50% of patients with asthma reporting days missed, particularly from school in this study, since this is the children. And then when you look at the absolute numbers, this is 12.4 million. So these are per million. And that unfortunately has not changed that much in the last 10 years. We still have a lot of morbidity again and days missed of school by the children diagnosed with asthma. It affects greater than 25 million people in the US. 6 million of those are children defined as age less than 18 years. Well over half of the children will have experienced one flare per year. And this again is all data from the CDC. 1.6 million ED visits for asthma were noted in 2018. It still carries a 13% mortality rate in adults. Not as much, thankfully, in children, but it's still there, close to 3%. And then this diagram or graph is also from the CDC, and just again going through your emergency room visits. Again, not much change in the years. There's some subtle declines over time, but well over 1 million visits per year, again, from 2010 to 2018, accounting for asthma. And then the mortality rate is the one on below. That shows, again, some decline over the years, but still affecting quite a number of people. And certainly looking nationwide and kind of figuring out where we are as a state, Arizona is sort of in the middle. So we have about 7% prevalence rate for asthma in our area, compared to sort of California, our neighboring states. They're all sort of varied. The Northeast still tend to have higher asthma rates for different reasons. And then you still see a little fluctuation in sort of the South in the Midwest. So going into sort of asthma treatments, I just want to give a few of the abbreviations that you'll see throughout the rest of the slides. SABAs, S-A-B-A, short-acting bronchodilator. ICS are your inhaled corticosteroids. Your LABA is your long-acting bronchodilator, and your LAMA is your long-acting muscarinic agent. So going back to this chart, again, you've got your classification and your diagnosis of your patient, if they're intermittent, mild, moderate, or severe persistent asthma. And now you match it with kind of what's called step therapies, step 1 all the way up, and we'll show what those actual medications look like. So as I mentioned earlier, we have newer guidelines that came out in 2020 that put a few revisions on that step up or step down type therapy. One of the important ones is regarding your age 0 to 4-year-old individuals where they have this recurrent wheeze. And again, frequently we have kids that might come, this is maybe their first or even their second time. And we're really not sure if this is going to go on to asthma. They don't have all of those risk factors that we saw in our own vignette. So they may just have, rhinovirus or RSV or even the influenza and associated wheezing with that. So the idea is really following the pattern. If it's becoming recurrent, which is defined as 3 isolated episodes in lifetime or 2 isolated episodes in a year, this is where you're starting to lean towards an asthma type of diagnosis and maybe initiating step therapy. The difference is in your intermittent and even your mild persistent. Intermittent, we recommended just using your SABAs, PRN, or as needed. Mild persistent, starting out with low dose inhaled corticosteroids. The newer guidelines now say if they're intermittent, you can actually do a short course of ICS for 7 to 10 days in addition to your albuterol or your SABA as needed. So that's this part right here. That's what was changed for 2020. And again, this is for your 0 to 4-year-old individuals. So from your 5 to 11, what was change and notable. Again, in your mild persistent asthma category, we usually will start with your low dose ICS. And many of us would recommend doubling or escalating ICS when they are symptomatic or in their yellow zone of their asthma action plan. And we'll touch on that in a little bit. That no longer is recommended. We stay kind of with low dose ICS, and we either increase or step up therapy if we feel the severity is worsening, or if they're in that moderate to severe asthma, new guidelines actually incorporate this idea of what's called SMART therapy. Again, we'll talk about that in a second, where we're using your ICS LABA agent, Symbicort in particular, as both a maintenance medication as well as an as-needed medication. So that's this part here. Then if you look at greater than 12 years of age, again, starting with your mild persistent asthma category, what was changed is you can still do low dose inhaled corticosteroids as a start, but you also have an option of doing albuterol as needed or your SABA as needed, followed by QVAR in particular, every 4 hours for a couple of days and then stopping, as opposed to remaining on a daily ICS. So there's an option of doing, again, this sort of PRN treatment similar to the 0 to 4-year-old group for a couple of days or actually a couple of weeks, and not necessarily having the patient on medication for months and months on end. The idea of SMART therapy still exists in your greater than 12-year-old. What changes is the amount of puffs at maximum that they can get in a day. So that's what you're seeing here. So SMART therapy, single, maintenance, and reliever therapy. That's what it stands for. And the therapy is really specifically used, or the studies, I should say, specifically shown with use of Symbicort with budesonide and formoterol. Their properties of formoterol, which make it more favorable in terms of the action. And the idea is that each time a patient is having an acute asthma exacerbation, they're actually receiving inhaled steroids along with the bronchodilator. Longer term, they've seen less growth suppression with SMART therapy. There's definitely concerns, especially as we elevate the concentration and the dosing of the inhaled corticosteroids, that we go on to have growth suppression in our kids. So this was something that they looked at in the studies. One of the more practical caveats as we start to implement this type of therapy is we're running into issues with insurance not covering the supply that's needed to serve as both a maintenance dose and a PRN dose with Symbicort by itself. So we also have use of muscarinic antagonists. In many times with the asthma exacerbations, we have added ipratropium bromide or Atrovent to help out alleviating symptoms. So asthma has an increased cholinergic tone, so your anticholinergics are sometimes helpful. And there are studies that show it reduces hospital admission, and we can see some improvement in lung function during acute attacks. Taking this more of a chronic management, there's now a long-acting agent. This is now the muscarinic, long-acting muscarinic agent, which is tiotropium or Spiriva specifically. There is Spiriva HandiHaler that's approved for COPD, and the Respimat, and these are just the differences in administration of the medication and a little bit of dosing. But the Respimat is particularly the one particularly approved for children in management of asthma. So it's approved in the US for children ages 6 years and above. And it does show improved lung function and asthma control when it's used in addition to an ICS or even an ICS LABA agent. So again, severe persistent asthma or not well controlled moderate persistent asthma, you can add that LAMA to an ICS LABA therapy or add it directly to an ICS therapy if for some reason you cannot transition onto ICS LABA. So this is a chart that we get from this organization in the corner. That's pretty accessible to all. It goes through the medications that are available. And it lists them or categorizes them from your short-acting beta agonist, long-acting inhaled corticosteroids, etc. So this is a pretty handy chart just to keep in mind of all the different medications that are out there, what their indications are for, which are approved for children, which are still approved or approved only for adults, COPD versus asthma. So we have this in the office, and I usually encourage even our colleagues in Gen Peds to have it because I think it's just really handy way of memorizing or knowing the medications. Sometimes it's also helpful for families when they don't remember what they have at home and you show them this and they can point to the pictures. So let's do another poll. So going back to the child that we've diagnosed with mild persistent asthma, what is the most appropriate initial therapy recommended? Okay, I'll give it another 30 seconds. All right, so good. So most of you guys chose daily low dose inhaled corticosteroids, which is where we want to go. So daily albuterol is not necessarily the initial therapy for mild persistent asthma. Remember the newer guidelines, and perhaps my error, I should have probably put an age range to help. The newer guidelines will say from 0 to 4, you can use your SABA or your albuterol daily, but you still want to use it in conjunction with an ICS for 7 to 10 days. Otherwise, we really hardly ever recommend using daily SABA as a standalone therapy. If they are mild, and that's if they're intermittent, or you're not really sure if they're going towards a mild persistent picture. But if they're confirmed mild persistent asthma, you really want to start with a low dose ICS, such as Flovent. All right, so moving over to biologic agents. I feel like a picture is worth 1,000 words, and kind of remember your Th2 cell here and the fact that they secrete certain interleukins, IL-4, 13, and 5 being the predominant ones that we're talking about right now. And those are the stimulants for sort of this cascade. They stimulate your eosinophils, your mast cells, your IgE, and then you have sort of your increased mucus production. You have smooth muscle hypertrophy, your airway obstruction, hyperreactivity. So all the things that we're concerned about with your asthma exacerbations. So these are the two highlighted areas because these are the areas that the biologic agents or the injectables are targeting. So one of the first ones that we had use of was your omalizumab or your Xolair. And that's the one that's your anti-IgE monoclonal antibody. And it's the only one that's actually based or dosed off of your IgE levels. Your dosing can be monthly or every other week, and it's dependent on your weight, age, as well as your IgE levels. It's now approved for greater than 6 years of age, and you can transition these kids to home dosing once they're over the age of 12 years. They have pre-filled syringes, which the families can actually use. There are a number of other conditions that Xolair actually is approved for use in, but again, asthma is our main focus, and we do use it on more of our severe asthmatics. Mepolizumab or Nucala, the other one that came out, it's your anti-IL-5 monoclonal antibody. So all the rest here on after are based on your interleukins. And really, you're looking at your eosinophil levels to decide if the person or child is a candidate for therapy. And then you can make the decision which one they would best fit. So again, based on eosinophil levels, this one is dosed monthly. It's also approved greater than 6 years of age with home dosing approved. Then you have benralizumab or your Fasenra. This is also anti-IL-5. also based on eosinophil levels. The quote unquote plus for this one is of all the injectable agents, this one has the least amount of dosing per year. So after you do loading doses, this medication is then given every other month. So you end up doing, so it's 3 loading doses and then every other month. So you end up doing about 8 in a year. So for some of the families that just compliance is an issue, sometimes this actually helps in that sense. Again, approved for greater than 12 years of age, and home dosing is approved. And last but not least, actually I take that back, there's one more, but I think this is the last but not least one that we probably use most in our clinic is your dupilumab or your Dupixent. And this one's anti-IL-4 and 13, also based on eosinophils. This one's dosed every other week. It's relatively recent. Now this is about 6 months old, but you now can use it in 6 years of age and older for asthma, but you can actually use this medication as early as 6 months of age. And the big difference is what it's approved for. So this medication came up approved for use for atopic dermatitis before they really transition over to asthma. We've even seen some improvement with kids of EOE on this injection. And so the age criteria hasn't caught up fully with the clinical part. So there's some caveats between that, but technically you can use it in a 6-month-old with severe atopic dermatitis. Home dosing is also approved for these kids. So here's sort of a pictorial representation of what we're looking or what each drug is sort of targeting. Again, these 3 are eosinophil, or this is what we need to look for when we're deciding if to start therapy for the patients, whereas your omalizumab is IgE. The really last one that's been out so far is Tezspire. I personally have not used this yet. The pediatric data is a little bit more sparse compared to the others, so kind of a waiting and watching on at least my personal end. But it is actually approved for pediatric patients older than 12 years of age. Thymic stromal lymphopoietin we didn't show in that diagram, but it's in that area of being stimulated by your cytokines, and this medication sort of blocks that cascade, and you can dose it monthly. So going to the next poll, all of the below therapies utilize eosinophils as biomarkers except. Okay, we'll give like another 30 seconds. Ooh. Oh, sorry about that. Okay, there we go. All right, so we have a little bit of a split. So all of them except omalizumab. So all of the other 3 are really looking at, or they're targeting your interleukin. So you're really looking at your eosinophils as your biomarkers. Your omalizumab is the one that is targeting your IgE. So that's actually the one that we utilize for your omalizumab. All right, so goals of asthma care, again, reduce your impairment, that top half of that graph or a chart, and reduce risk. And the way we try to do that in the clinics is when we see them in the clinic, we sort of assess control, what their current symptoms and if they were in the emergency room or needing oral steroids to assess their risk. We sort of review medications, techniques, and inherent adherence routines. And if we feel that we need to change, in both directions, step up or step down, then we change the medications. We revise your asthma action plan, which is kind of that written documentation of what they should do on a daily basis, what should they do when things are starting to act up, and what should they do when they're really in trouble. And then we schedule that follow-up visit. We try to follow up patients really in a 3 to 4 month range on a chronic basis. Certainly, if they're more intermittent or even a little bit on the milder side, we might stretch it out to 6 months or even a year for your intermittent patients. But most will fall into that 3 to 4 month range so that we can review the sort of cycle. So what are the greatest barriers to good asthma control? And you guys can actually type in what you think it is. See if it pops up. Yeah, so these are really good. And they actually are all in there. So compliance and adherence are probably the number one. Unfortunately, that's accounting for barriers. It's tied into actually patient education, not recognizing symptoms, and just education as a whole. So you guys actually came up with all of them that we see. So again, perception of asthma control, we utilize ACTs, asthma control tests, a lot. It's a validated questionnaire nationwide. The other two are also validated, and you'll see them, I think, they tend to target a little bit more of the severe asthmatics as opposed to the more general or mild to moderate population, but they exist and they're also validated. All of them really are trying to assess well control, not well control, or very poor control of your asthma. They try to ask those questions that are in that impairment section in terms of your symptoms, your nighttime symptoms, your activity limitation, and how often are you using your relievers. And poor control correlates with future exacerbations. So it's actually a really good tool because you can use it to help patients identify and see for themselves if they're well controlled. You can use it if there's a discrepancy that perhaps what they're telling you on paper isn't matching what they're telling you when you ask them these questions directly, and you can utilize the questionnaire to sort of bring their attention or bring their focus to that. And then you can utilize it to monitor, as you make changes in medications, hopefully as you educate and they're hearing you, that score is going up. So unfortunately, only 8 to 15% of individuals are shown to be fully adherent with their therapies. I was terrified and really disappointed when I learned this statistic myself, but it is been replicated in a couple of studies that we have really poor rates of adherence with asthma therapies and probably chronic therapies in general. Patients with low adherence tend to be younger, and probably that's because we put the blame, unfortunately, on the parents a little bit. Fewer PCP visits and lower ACT scores. So education, as you mentioned in that other sort of questionnaire, education or lack of education is really important. So part of the reason, that we try to see patients so often is that we can spend time hopefully educating and re-educating each time they come, the importance of the medication, what the actual medications do, how do you actually use them. There's a skit that I know the residents, I've bothered them about, but it was on House, and they actually had a lady come into the office and say that her asthma was under poor control and that she was using her inhaler. And when the doc asked her to demonstrate, she kind of put the inhaler to her neck and used it sort of perfume. And it was funny as a TV show, but it actually is some reality to it. We have individuals that do not use spacers or use spacers incorrectly with these inhalers, and unfortunately, when to use them, how to use them gets missed a lot of times, and it's very confusing for the families. So all of that plays a role into overall asthma care and the fact that we need to educate our families about all these components. There's still hesitancy about steroids, even though these are inhaled steroids, and even though we try to counsel what dosing the patients are getting, and the benefits versus the risks of using the medications. So we try to go through that with families, incorporating them into day-to-day schedules, incorporating them into schools and having school nurses on board with recognizing symptoms, helping kids during recess and PE, things like that are all needed education to maintain good asthma control. So I think I'm going to conclude with this slide that just goes through sort of future directions of research. And there are quite a few. Like I said, we can go on and on about asthma for a while, you know, from the different types of medicines, the administration, nebulizers versus inhalers, et cetera. But these are sort of I would like to think sort of the eye-opening ones, future directions of research. So this idea of hygiene hypothesis, using prebiotics and probiotics for the restoration of your lung and, more importantly, your gut microbiota, which would be helpful for controlling asthma down the line. Along this line, and here in our own institution, we've been looking at asthma severity with fiber. There's a long hypothesis that your quote unquote Western diet is lower in fiber. And that is one of the reasons that we're seeing increased asthma prevalence in sort of the Western society. And so taking a look at that and other dietary intakes and habits and realizing the association between asthma and perhaps seeing if we can make changes in dietary intake to help with asthma prevalence and asthma control. Therapy for neutrophilic asthmatics. As I mentioned, these are the groups that tend to be the more severe, and although they're not the most number-wise patients that we see, they still account for a good 2 to 3% of the population. And we struggle because they don't have the greatest response to, again, the inhaled steroids and a lot of the typical courses that we just went through in terms of treatment for asthma. School-based asthma therapy, as I mentioned, for kids, this is kind of a partnership. We need the school nursing to be helpful in recognizing symptoms, helping with adherence for these kids, and still encouraging them actually to participate in exercise and activity. So there are some studies looking at giving daily medications, daily inhaled corticosteroids at the school, and if there's improved adherence through that. And then, of course, tailoring the therapies to kids from different ethnic groups. There's a lot coming out about the different ethnic groups that you know, will respond to certain therapies more so than others. For instance, African Americans, one of the studies had shown that going up on sort of inhaled corticosteroids before stepping up to an inhaled steroid plus LABA agent can have more weight and more improvement in African American children than previously thought. So looking at that and really tailoring the therapies to each ethnic group is another sort of avenue. And I think with that, I'm actually done. It's hard to see if there's other questions and stuff there, so I'm depending on you a little bit, Dr. Hartley, but feel free.
Okay. Well, good. It usually takes a minute or two for them to come in, but I've got one of my own.
Okay.
When you showed the slide about asthma mortality, you know, in adults, and you know, it was much higher in adults, but even in kids, it seemed like it was higher than I would have expected. And so I'm just wondering if you could comment a little bit on kids that actually, you know, die from asthma, you know, where do they die and what is it from? Because I can think of, you know, one of my favorite M&Ms over the years was when Dr. Buttram and her team, you know, saved a kid who was, you know, dying at an outside ED and barely got here. And then I can remember I had a kid on the ward once that coded at home and, you know, barely made it.
Great.
But, you know, I can count on one hand the kids that I can think of that almost died. So, you know, the kids that do die, are they dying at home and we just never see them, or are they going from the ER to the PICU and dying there and I never see them on the wards? Or, you know, what is the backstory behind that?
Yeah, so take it with a grain of salt that that's about 5 years old, but at the time it was more, they were not home, they were actually at outside, so I don't want to say that, but they were at smaller hospitals. And so part of it was kind of this access to care. Part of it was the time frame that they got to these hospitals or urgent care units, I should say. Their symptoms had already progressed. So a lot of these kids really were going into cardiac arrest at home and then seeking care. And that again was about 5 years ago. So by the time they hit sort of the emergency room, there either wasn't enough, intervention that was available before they can maybe get to a higher level of care type center, and they passed away, or they did make it to higher care centers, but they were already, already gone and pronounced dead by the time they got there.
But not so much a failure of the therapies, but the failure to access the therapies in a timely manner.
That and recognition. So I think that what they highlighted in those studies is that by the time the families came out, and it sounds like the two cases you mentioned were probably in the same route, is that by the time these families even sought care, the kids were already far gone.
Yeah. One of them, I still remember, but it was, the mom just did not appreciate how sick the kid was at home until he was, stats were in the 60s when the paramedics got there. So the second part of that, of those kids that have the worst outcomes, how many of them were, say, plugged in to severe asthma clinic and adherent to therapy, and how many of them, would never have got there had they been plugged into a severe asthma clinic and adherent to therapy?
That's a good question. I don't remember that really out of the literature commenting on the association of where they were going. And to be honest, thinking back to those papers, I don't know if they really even commented if they were seen by specialties or if they were managed by PCPs, or even if they saw their PCPs. So that actually is a good question. I'm not really sure, and I haven't seen or done any digging to see if there's a correlation between those who really do have established care versus those who don't, whether it be PCP or even specialty clinic. So I'm not sure.
Okay, very good. Now we have our first question from an attendee. He said, can you comment on the history of the safety with long-acting Bracobas?
Oh, so I'm going to somewhat assume that you might be mentioning when they had that black box warning when we were using salmeterol. Is that, I don't know if
I would guess that is the case too.
Is that where we were going? Okay, so yeah, so the studies have shown when you use long-acting beta agonists by themselves, and the big ones were salmeterol in particular, or Serovent was the name at the time. Formoterol is another one, or Foradil is the name for that one. The concern was that they were saturating your beta receptors, and so by the time you needed rescue, there was no availability for the rescue medicines to bind to, and that did lead to increased morbidity and mortality in the patients that were on long-acting beta agonists by themselves. That has since kind of gone away, I guess, or improved in the sense that we don't use them by themselves. We're now using them in the combinations. So your salmeterol is a part of your Advair, so your fluticasone and salmeterol, and your formoterol is part of both Symbicort and Dulera, Symbicort being budesonide and Dulera being mometasone plus formoterol. So hopefully that answered your question. If not, let me know.
Okay, no, thank you. I think that's an excellent answer. Okay, here's a couple more just came in from your colleagues. Dr. Bacci says, excellent presentation. What is the best strategy to implement smart therapy in Gen Peds, especially with the issues of insurance and risk of confusion for patients?
Oh, Dr. Bacci, you caught me on the spot. I don't actually know yet. We're trying to figure it out ourselves. I honestly am not sure yet. I think we internally are trying to adopt it as well. We know the studies are showing it. I've done a couple of peer-to-peers to try to just get additional inhalers. And usually if you show them the literature, they'll bite. So I think that's where we're going right now. But I also don't have a great answer for that yet. I'm not sure what other centers may be doing to get it implemented better than where we are right now.
Okay, and from another pulmonologist here, I have a hard time using inhaled steroids only with wheezing episodes in the little wheezers because we were always taught there was not good evidence to support that in the past. Do you know if there was strong evidence that guided the change in the guideline?
Yeah, so I am also on board with that. I don't think I've crossed over. So what that comment is pointing back to the 0 to 4-year-old individuals where they're having recurrent wheezing. And that guideline is saying that you can now do albuterol plus an ICS for like 7 to 10 days. And they actually do have pretty strong evidence for guiding that change. But I think I personally agree. It's been hard because we're usually taught that once they're going into this recurrent phase, you're crossing them over into a mild persistent asthma category anyway, and usually we start inhaled corticosteroid therapy. So it is a hard crossover, but they did have strong evidence that guided that change for the 2020 guidelines.
Okay, thank you. We've got some of our residents are coming back here to Cohen, so I'll give them a chance to ask a question. And while we do that, I wanted to make a brief plug because some people joined late. So see if everybody's going to see. Okay, this is a new thing that we have in CME. Let me get to right now. So here's the new PCH page, and I need to move something out of the way here. Okay, sorry, there we go, right here. So everybody can find our grand round schedule right here. You have to scroll down a little bit. And so here is your grand rounds here, November 1st. We try to keep this up to date. And the cool thing is, starting within probably an hour or two from now, if you missed the first part of Dr. Williams' presentation, you can come here to Archive CME and you click on that once it gets moved over, and we should have the video up hopefully 80 or so % of the time within an hour or two after grand rounds ends. So for those of you who missed the first 10 minutes because you're dropping off your kids or something like that, you can always watch it at lunch or later on or anytime in the next week or so. Because this was a really great presentation, and there are a couple of spots where my attention was called elsewhere, and I'm going to go back and catch up on it. So with that,
So I did want to also just toss in, I know one of our colleagues, Dr. Rankin, is a part of a team that's looking into implementing these guidelines because they are different. I mean, it was 13 years before we had any types of changes. So hopefully we'll have more structure from that, study of how to even implement them and what that means. But I just wanted to toss that in there too.
Okay. Well, thank you so much, Dr. Williams. This has been a great talk, and especially at the last minute, our usual surgery grand rounds on the first Tuesday of the month got canceled. So I really appreciate your stepping up to the plate and giving this talk. I heard it at Update, and I heard it again today, and definitely got something out of it the second time, and I may watch it a third time.
Okay. Thanks, Dr. Hartley.
Okay. Well, thank you
Have a great morning, everyone.
and I think it's time to go see patients. Okay, bye-bye.